Welcome to the third HITSM post-HITSM chat. We decided it was called HITSM, not HITSM like some people like to pronounce it. Today we have Nathan DiNiro here, better known as Uncle Nate, also an advocate of everything open healthcare, and a lot of other things. And of course I'm John Lynn, at EHR and HIT on Twitter, and also at Tech Guy. So glad to have you here, Nate.
Thanks a lot, John, for having me. Appreciate it.
Yeah, it's a little uncomfortable seeing you in sunny Portland. I didn't know Portland had sun, but
Well, I just sent out, I think yesterday or the day before, a picture of my new seasonal office down by the pool here. I have a nice long-range Wi-Fi antenna that I installed, so I can get an excellent signal down at the pool. So.
Yeah, I could go to the pool here in Vegas, but at this point I'd fry. So
maybe if I'm on next week, I can do it poolside.
Yeah, that would be nice. All right. Well, there were a number of topics today. Kyle Murphy from EHR Intelligence hosted it and came up with the questions. I thought he really chose some interesting, deep questions. And I think the first couple were really about interoperability. Was there something in the chat that really struck you?
Yeah, I mean, I have my own struggles with interoperability, but it's clear that everyone across the industry still struggles with it. I think that one thing that came out of Health Data Palooza, even though I wasn't there, and some of the follow-up patient meetings at the White House that happened this week, was that there's not an awareness of Blue Button out there in the marketplace, and if you know anything about healthcare, you know that that's an interoperability standard to allow patients to get their data.
Yeah, it's been 8%, I think, right? For is how many people actually knew about the Blue Button so far? That's what came up.
It's pretty low, right? And I think the ONC realized after Meaningful Use started to get rolling that they needed some patient component, and fortunately brought in Ligia Ricciardi, who is now officially the director of that Office of Consumer Issues. But I think that's one of the difficulties behind Meaningful Use in general getting traction, is that it's a government requirement, and we're telling providers that they need to adopt this stuff so that we can switch the payment model in our system. Mm-hmm. But that message hasn't really reached the consumer yet. And it's only really reached the consumer in all of the fights that they've seen, over health reform. Not necessarily the fact that the trains left the station, and we'd like them to get on board, as well.
Yeah. So isn't that one of the problems with kind of interoperability in general, is that the patients don't necessarily care. In fact, well, I guess there's two sides of it. The patient looks at it and says, "Oh wait, this isn't happening already," right? Like, I think they just kind of assumed their doctor.
They assumed it was happening before Meaningful Use.
Yeah, exactly. So they assume it cares, but then if you really dig in and you say, "Hey, do you want your data shared online with other doctors?" Then they get this fear, like, "Wait a minute, if it's shared, what will happen? Will I get higher insurance premiums? Will my patient data be private?" And so, that's the problem from the patient side, I think.
Yeah, I mean, there's a whole set of hidden, unintended, consequences or areas of the market that need disruption or information or education. I mean, I remember a call I was on last week with the Collaborative Health Consortium and Vince Caritas, bringing up the fact that without the transparent market, or without transparency, you don't have a market. So without price transparency in terms of what people are paying for, there won't be a market, and people are still making that transition to having care that's delivered in a managed way as opposed to a fee-for-service model. I mean, so the fact that because we're in this transition stage, it's really easy to throw stones and freak out about various things, but at the same time, who wants to be the guinea pig?
The other thing that's related to that is, like, I think there was a discussion of, is Meaningful Use driving interoperability, And someone made the comment that they thought that the ACOs and the value-based care was what's really going to drive the interoperability much more than meaningful use.
Yeah, I mean, I can tell you that interoperability even between ACOs and CMS is rough at best.
You're nice.
Well, yeah, I mean, I'm being very nice, but it's to be expected. We're building a jet engine in flight, or we're actually refactoring or redesigning the jet engine in flight. So.
I mean, it feels like a motorcycle guy was almost, I don't know if the word offended is right, but he was kind of upset at, I think it was Dan Haley from Athena Health who kind of insinuated that meaningful use wasn't going to get us to interoperability. And I think there was a little tension there, like he's like, wait, what do you mean? Like what would you like it better? And Dan came down, I guess he's been hanging out with Jonathan Bush a lot, and came out and was like, definitively, yes, that's an issue. I'm not sure if you saw that.
Yeah, I mean, it's I'm getting old, John, so I have a hard time keeping up on these fast-paced electronic conversations that happen.
Yeah.
But no, I got the gist of all that, and I've come to know Athena's position on a lot of that type of stuff. In terms of the government and openness and all that. I mean, they're definitely they support that type of stuff.
Well, I actually sat down with Jonathan Bush yesterday, and we had this.
Oh, that's right.
Yeah, and he talked a little bit about the reason it's not working, the interoperability is not, and the change that needs to happen is there needs to be a financial instrument that supports the interoperability, and that came up in the Twitter chat today a lot, right? Well, the financial component's not there.
Well, the financial component should be to the provider better customer service. I mean, providers.
Is that enough?
Well, no. I mean, who had to pay the bank to give you electronic access to your data? I mean, no one had to pay the bank to create the system to do that. There was a financial and economic incentive for them to do that because now people can manage their money more closely. Or it gives them the ability to do that. And because today we still are in the transition stage between having our care just sort of paid for by a black box and the new age of when we're actually going to have a stake, that incentive doesn't exist. I think that's what will drive the market. And the interoperability piece and HIEs and sustainability and how transaction fees and all that kind of stuff. It's all going to come out in the wash. Eventually. I mean, one way or another, it's gonna. I mean, how many businesses started in one direction and had to pivot a number of times to get someplace else or get to their successful place or their happy place. So.
Yeah, I mean, for me, at the end of the day, I think I tweeted this. A few other people did. That interoperability is not a technical challenge. Sure, there's a lot of technical components to it and a lot of legwork that's required.
It's economic and political.
Yeah, but that's not why we're not doing it, right? We're not doing it because for some reason we can't send the data or that there's not a secure way to do it. We're not doing it because there's not the financial incentives to do it. And to your point, if every doctor was doing it, then or even half of the doctors were doing it, then the others would have to hop on board because of that pressure, which I think is what happened with banks, right? The bank said, I want to differentiate myself, so I'm going to share it online. And then once a certain percentage did, everyone else said, well, if I don't, no one will use me. So,
Yeah. Yeah, and it took 5 years for that to happen, really. But, if it takes healthcare 5 years to do it, then it would have, 5 years ago, it would have taken 15.
Yeah.
There's the whole wacky concept of the singularity, and as technology continues to evolve, it feeds into itself and accelerates the pace of technology essentially. So,
right.
While like I said, 5 years ago we might have thought it would take 15 years to get to the point of a transparent kind of market of information and dollars flowing because of that transparency. I think it'll happen much quicker.
Yeah. I'm not, if we're making predictions, I'm not as positive on
You're not as rosy.
Quickly. My outlook's not as rosy as yours. So another topic that came up, I think the third topic was about telehealth, and I loved one of the tweets. I can't remember who it was that sent it out. They said something to the effect of, "I would definitely do a telemedicine visit." Oh, I think it was actually Brian Eastwood from CIO magazine. He said, "I would definitely do a telemedicine visit rather than trying to brave the traffic to get to my doctor." Right?
Uh-huh.
I think that's a common feeling. And someone else said, well, not everyone feels that way, which my response was, pretty much everyone under 40 does, right? Feels that way, or at least.
Yeah, I'm sure it depends on your condition. I mean, I certainly see it as having a tremendous amount of value in helping to relieve some of the costs and the stress it puts on the most vulnerable.
Uh-huh.
And the most expensive people to care for, but they're the ones who are least likely to have the technology. So it's something I've been researching more and more. How to get that technology into their hands,
Sure.
Because I think that's certainly an area, where telehealth can help a lot. And I've also talked to some other docs who work in rural settings. Or even in third world settings, where sometimes people will have conditions that are stigmatized, and often in mental health, where now telehealth provides access that wasn't necessarily there previously. So, there's definitely a lot of value in it beyond just the convenience factor. I think that we may look at or you under 40 may look at.
Yeah, I like the under 40 group, but
I like it too.
Don Fleckinger from Search Health IT, he said, coming out of ATA, right, the telemedicine conference, he said, coming out of that, he said, I realized that telemedicine is one of the ways that we could lower the cost curve, right? That he really sees that potential. I think that's true, but then I'm actually working on a post now about the idea of, Google Glasses, which in some ways could be considered telehealth, but imagine an emergency responder, or even just an average person, right, that's walking down the street, someone's laying on the ground, bleeding or something. They could, with their glasses, tap into an emergency responder who will see that person and give them instructions, hands-free, to be able to treat that patient, that injured person.
Or at least like maybe apply some pressure or save them from bleeding to death or something.
Yeah, exactly. They can instruct them. They can say, calm down, do this. They can, just like you would on 911, but it would be hands-free. And then 911 operator, whoever it is, probably will have to be someone more, since you'll be able to see.
Yeah, we've been toying around with the idea of the glass a lot. I mean, I know a lot of people say, it's a consumer device, and while it might be geared towards consumers, I still think that as a mode of human-computer interaction, I mean, it's obviously we're just scratching the surface of it. I mean, one of the chief complaints that docs have about EHRs is it takes their attention away from the patient, and complaints by patients as well. So,
could glass solve that? Yeah.
We've been toying around. Want to get a hold of one, and I was very happy to hear that last week during one of the presentations at Health Data Palooza, they had some Google folks there who were having difficulty getting their presentation going, and one of the guys, I can't remember his name exactly, who was from Google Ventures, was basically saying, like, healthcare people, please send us your ideas, because we're interested. And I can say that in the OpenEMR ACO world that I'm operating in, we've started to have some discussions about trying to acquire a glass, because, I mean, being able to interact with a patient and potentially have a base level of interaction with an EHR system that is completely hands-free and driven by, maybe a combination of like nuances, technology, their voice recognition technology, augmenting what Google's doing with theirs, allowing the doc to actually look and talk to and put hands on the patient, lay hands on the patient if they need. Just all kinds of things that it could potentially allow is huge. And then, the same week when I was in Vegas, I had a meeting with a telehealth company that you probably know of there in Vegas, and talked to them about some of the amazing stuff that they're doing, and just telehealth in general, that that it offers the type of patient or beneficiary, if you will, that you'd find in an ACO or in a Medicare, Medicaid environment. The whole issue of readmits and reducing readmits at the hospital. I mean, there's just so many uses and potential for it.
Yeah. I mean, I imagine even with my kids, right? I mean, if I had glass and I was in a telemedicine visit, I could show them what they're looking at. I can pull up their foot, and look at it.
Well, this mode we're using right now is the perfect sort of environment for telehealth visits. Adobe actually has a platform called Connect that's used for online meetings. I used to use it and sell it years ago in an old agency that I had. But these types of interaction models in healthcare are just, this is what we should be doing.
Well, and that's what's interesting too, right? Like you and I, yesterday, I said, you want to come do this video hangout after the HITSM chat? And you said, yeah. And I said, okay. And I started it up. We'd never connected before. We'd never done a video conference before. And yet we were able to connect seamlessly without any issue. And so once that becomes ubiquitous,
well, and you invited me through my Google address, which is my blue button, or my direct address rather, and and it's also linked to my PayPal, so you can reimburse me for this visit, and all that sort of stuff, right through your Google Wallet.
That's right. I should just collect it through the Google Wallet. That makes sense. Great. Well, it was good discussing this. There were some other discussions. I talked about deadlines for meaningful use and whether that will undermine healthcare reform. It seems like everyone said no. It's going forward regardless.
Yeah, I mean, they move. They make exceptions where necessary. I mean, they've done that with meaningful use in the past, so they'll continue to do that, I'm sure.
Yep. I mean, everyone's mired in government regulation right now. That's where we're at in healthcare.
Well, and I know Jim Tate, and I'm sure you've probably seen some of his recent emails about the meaningful use audits starting to come out now as well. So I have to imagine that last example of a certified EHR losing its certification, we all knew that was one shoe. There's many other shoes that are going to drop.
Although I'm told that they didn't really have any providers, so it's kind of here nor there, right?
Yeah, it was a kind of a weird. I delved into the company a bit. I don't necessarily want to disparage anyone or talk about other companies, but it was a head scratcher.
Sounds good. Well, I guess we'll wrap this up with a tweet I just got from Vince Caritas, who, man, if you want to read a good Twitter stream, read his. He had some good offerings today, but
Uncle Vinny.
He said Anderson Cooper and Oprah are calling. Which one do you guys want to talk with first? And maybe Vince is the Anderson Cooper of healthcare IT. Right?
He could be, maybe. I don't know. He needs a show.
I'm not sure who Oprah is. Maybe it's Mandy B. Pro, right? So, anyway, thanks for joining me. We'll probably do it again next week. I think I'm out of town the week after, so I'm not sure if anyone will do it. But, anyone's welcome. We like to include a lot of people in this. But it was good chatting with you, Nate. Thanks for joining us.
Thanks, John.